Good evening, friends. Today we are going to talk about anesthesia management in endovascular neurointervention. If you look at the progress in last decade, interventional neurology is a rapidly advancing clinical area, and complexity and diversity of interventional neuroradiological procedure increases, the demand for anesthesia also increases. So we need to develop along with the way these procedures are increasing. And anesthesia for interventional neuroradiology is a challenge for the anesthesiologist due to the unfamiliar working environment, which the anesthesiologist must consider, as well as the unique neurointerventional components. So environment is not just like our operation theater environment. We are working in cath labs, and there is a space constraint because there is things like C-arm and all those things, and uh, even staff members are not fully trained to support us. During endovascular procedures, anesthesiologists are intimately involved in sedating the patient, anesthetizing the patient, monitoring the patient, managing hemodynamics, oxygenation, ventilation, and glycemic control, and managing the perioperative complication, all of which may have a significant impact on patient's long-term outcome. So we need to monitor and treat all these things so that patient have a better outcome. These procedures are many times emergency procedures. We do not have enough time for preoperative assessment or optimizing the patient. We need to take the patient inside the procedure room in emergency without adequate assessment and investigation, and they are real challenges for us. So if we take a tour to the neurointervention shoot, here it is like this. This is the console of cath lab. From here you can monitor everything. Here you can monitor the radiology snapshot. Here you have monitors so that you can monitor the patient by sitting inside this room and avoid radiation exposure. So if you intubated the patient is on proper, if you have availability of anesthesia machine and proper ventilator, you can just put the patient on infusions and anesthesia ventilator and monitor from away so that you don't have radiation exposure. There are other things which can help you in the radiation exposure, like you can have lead gowns, then thyroid shields, even specs. You should stay as much away as possible from the patient, like because ionizing radiation follow the inverse square law. That is, the radiation exposure drops off proportional to the square of the distance from the source. So when you go away from the patient, radiation exposure decreases. And if you are on the patient's head and exposure of the radiation is maximum, so you should intubate the patient, take long extension lines and long anesthesia circuit, and stay away from the patient as much as possible. Uh, this is the neuro interventional suite or cath lab. Here you can see this is the table where patient lie down, and this is the C-arm. These are the monitors where they monitor the you know, patient's vital as well as radiological images. If you see here, this is the anesthesia workstation inside our operation theater. We have continuous supply of oxygen, air, and nitrous so that we can manage the things. We have monitor with ECG, NIBP, SpO2, ETCO2, and anesthesia gas monitoring. So it is completely equipped just like operation theater anesthesia workstation. This is a vaporizer of sevoflurane. So we can manage the patient in a better way. Here you can see this is the crash cart where you will find all emergency drugs. This is the defibrillator. So all facilities are available so that you can treat the any emergency situation if in case it happens. So you should be prepared for any worst situation inside the cath lab. This is the C-arm. When they are doing this DSED or digital subtraction angiography, they take 360-degree view. So they move the CM in such fashion. So because of this, we have to manage our circuits and extension tubing in a way that it doesn't come in the way of 360-degree view. So if you see here, suppose this is a patient, this is actually volunteer for photography. So here you see the circuit, and when they move the C arm in the 360-degree rotation, you can see here that your circuit will come in the way, and if you don't take care, then it will get pulled off, and sometimes even endotracheal tube will come out along with the circuit. So you should be careful. You can stay on the foot and the end of the patient along with the long circuit, or you can manage in a way that circuit doesn't come in that 360-degree rotation. So these are some important basic things you should keep it in mind when you are doing the work inside the cath lab. When patient comes to you should go for preoperative evaluation. Basically, these patients sometimes are coming from the hospital where these facilities are not available. So they are diagnosed having a stroke. They sometimes they have ruled out the bleed or tumor bleed. So most of the time these things are diagnosed. Even if a patient has aneurysm, it is also diagnosed. So history of actual illness and its systemic effect we should look for. Neurological deficit in Glasgow chromoscal, this is very important because if patient is not conscious enough, we should go straight away for a complete general anesthesia rather than going in the conscious sedation. Symptoms of raised ICP. Suppose patient comes to you and the patient has symptoms of raised ICP, we should start treating it with mannitol and head elevation. We can intubate the patient, start propofol incision so that we can bring down the ICP. If it is present, the neuroanesthetist must maintain an adequate mean arterial pressure to ensure sufficient cerebral perfusion pressure. Because when ICP is raised, cerebral perfusion pressure is parallel to the mean arterial pressure. If we keep the mean arterial pressure higher, cerebral perfusion pressure will be proper. If it goes low, it drops. We have to look for the previous neurosurgical procedures and even previous any interventional neuroradiological procedures so that we can know about any contrast allergy or any renal dysfunction during that time. Renal function, this is important because we are using radiographic contrast. We should look for the radiographic contrast reaction, as I said. Another risk factor, contrast and flush fluid injection may be dangerous for renal function. So we should be careful about all these things. Allergy to any medication or history we should take. Then after looking at this, we should go for investigation whenever possible. We should go for full blood count, hemoglobin, blood group in the patient for a risk of bleeding. Urea and creatinine it is very important because we are going to use a lot of contrast material. Electrolyte abnormality may contribute to patient's level of consciousness. Sometimes if patient is hyponatremia, patient is unconscious because of that. So we should look for it. Coagulation screening is important with basal laxity fundamental because anticoagulation is required during the during and after the these procedures to avoid thromboembolic complications. So we should look for it. Glycemia should be assessed being a source of secondary brain. If patient has severe hyperglycemia or hypoglycemia, then it can lead to secondary brain injury. So we should look for it. We should go for ECG and echo whenever possible. Nowadays, ECG doesn't take much time, but even echo, many anesthesiologists are getting trained with point of care ultrasound, and they can easily do echo within a minute or so. So if you are trained for echocardiography with focus, then you should at least look for LV function and any other abnormality in the patient so that you can manage the anesthesia accordingly. But we should always remember that time is brain, and we should reduce the time delay whenever possible. So we should not spare too much of time in pre-op assessment so that patients real-time procedures they are delayed. So we should focus on the procedure which can help to the patient rather than delaying for some pre-operative assessment and pre-operative investigation. There is a constant debate between general anesthesia versus conscious sedation in this patient. General anesthesia has certain pros and like patient is completely immobile, patient is comfortable, and patient has good analgesia. So that neurointerventional radiologist or surgeon has high quality imaging because patient is immobile, completely immobile. Airway is protected. There is no chance of aspiration. You can provide proper oxygenation and you can control the CO2 level and you don't allow hypercapnia, which can lead to increase ICP. We can control the hemodynamic and respiratory variables, like we can induce hypertension with the help of anesthesia drugs. Whenever it is required, and as I said, we can have a controlled ventilation so that we can have proper SpO2, proper EtCO2, and it doesn't cause harm. But there are certain cons also, like there is no intraoperative neurological monitoring when we do give general anesthesia. With uh, newer modalities of imaging like evoked motor potentials, we can have some monitoring if we give TIVA and don't give muscle relaxant. Time delay, sometimes general anesthesia induction can take more time as compared to conscious sedation. There may be hemodynamic instability at the time of induction. Sometimes because of intubation, there is intubation response, there is a shoot in blood pressure which can be harmful in the patients with aneurysm or AVMs. And sometimes patient is unstable, there will be severe hypotension, like stroke patient hypotension is disastrous. Long post-procedure recovery after general anesthesia, recovery time is prolonged, and initiation of a critical care pathway will be done. So sometimes we'll end up putting the patient in the critical care unit because patient is intubated and we cannot extubate because of adequate reflexes. Respiratory complication of intubation may happen if it is prolonged intubation. Conscious sedation, again, the cons of the general anesthesia is pros for the conscious sedation, and reverse is also true. Like so that conscious sedation, it will be reduced time delay, hemodynamic stability, we can do intraoperative neurological monitoring, rapid postoperative recovery, and short monitoring period. While if you look at the cons, risk of emergency conversions, we need to convert to GA in case of vomiting or anything like convulsion, or patient become irritable. Patient's movement and discomfort and pain, which will lead to poor quality of imaging, prolonged procedure time, risk of aspiration, and risk of vessel injury from endovascular device because patient is continuously moving. So we should choose accordingly. Actually, if I talk about my choice general anesthesia, because you can control everything without a risk of any aspiration and you can provide immobile patient. But in carotid stenting, it is always advisable to go for monitor anesthesia care. In mechanical thrombectomy for stroke, it is like 50-50. Some of the studies say that you should go for general anesthesia, and some will say you should go for conscious sedation. If patient is cooperative, we can of course go for general anesthesia, but if patient is not cooperative, we should go for GA. So goals during procedure, we need a immobile patient with adequate comfort and analgesia and high quality imaging. So this is the primary goal of any procedure. Hemodynamic stability and maintenance of adequate cerebral perfusion pressure is another important goal. As I said, intubation response will lead to hypertension, and sometimes in hemodynamically unstable patient like with cardiomyopathy or previous any cardiac issues, induction with propofol will lead to hypotension. So we should be careful about it, and we should look for optimum cerebral perfusion pressure. Airway and respiration management, intubation is the gold standard. But if you use things like eye gel or supraglottic devices, second generation supraglottic airway devices like Procil LMA, we can have RISUP, and response to hemodynamic response is lesser as compared to intubation when we are using these devices. So these devices can also be used. Anesthetic drugs of choice, I'll say we have to go for um, analgesia, amnesia, and muscle reduction, all three components of balance anesthesia. So my choice is fentanyl, uh, propofol, and muscle relaxant. Either you can use atracurone or nowadays rocuronium, because when you use rocuronium, you can rapidly reverse with drug like sugamadex, and patient will have faster recovery with sugamadex without any changes in hemodynamics. Yeah. Dexmedetomidine is another wonderful drug which provide excellent hemodynamic stability without any fluctuation in blood pressure. So it is a drug of my choice. I try to use whenever it is possible. Even for conscious sedation, it is recommended drug. Management of blood pressure, again, it is important. You should manage the blood pressure intra procedure. I mean, in patients like aneurysm patient, you have to your goal should be to keep the blood pressure below 160 systolic, because high blood pressure may sometimes lead to aneurysm rupture. In patient with AVM, initially you require some little bit of hypotension during procedure. In initial part of the procedure, you require some hypertension so that you get blood flow in the surrounding area. While after doing the AVM embolization, it is suggested that you should go for a little bit of hypotension. In stroke patient, we opt for blood pressure between 140 to 180 systolic, because we need proper perfusion of the other areas of the brain. So according to the type of procedure, we should manage the blood pressure. Management of anticoagulation again is important, because during this procedure they use heparin so that there is no thrombosis because of intravascular devices. So they use heparin, but while using this heparin, you should look for the bleeding. A patient is conscious, under conscious sedation. In case of bleeding, you will immediately find it because of loss of consciousness. But if patient is under GA, then it is difficult to find. But there are certain signs like sudden bradycardia, hypertension, and even there will be a contrast leakage while doing the while injecting the contrast. So if it happens, we should immediately reverse the anticoagulation with protamine. We should give head up to the patient. We can give mannitol, propofol to reduce the ICP so the patient condition will remain stable. And propofol injection and antihypertensive drugs like labetalol help to bring down the blood pressure, and there will be reduced chance of bleeding. Recovery should be rapid and smooth. Drugs like sevoflurane will give rapid recovery. There should be no coughing or rise in BP. So what I prefer is I stop the inhalation agent, I continue the propofol, I extubate the patient in the deep plane of anesthesia, so that there is no rise in the blood pressure and there is no fluctuation in the ICP. Then you stop the propofol and make the patient conscious slowly. Another important point, as I said, if you use rocuronium or vecuronium, you can because these procedures suddenly surgeon will say that the procedure is over and you have to reverse the patient and extubate the patient. So in such situation, if you use rocuronium or vecuronium, you can immediately reverse the muscle relaxant by giving Sugamadex and extubate the patient. Because if you stop the inhalation agent and propofol, and if you wait for a recovery from muscle relaxant, sometimes there will be shoot in the blood pressure, and which is harmful in the patient. If patient is sick pre-operatively, we can opt for post-operative ventilation in these patients. There are certain complications like cerebrovascular complications, occlusive complication, peripheral systemic complication, or hemorrhagic complication. Hemorrhage is seen in the patient with aneurysm, AV or AVF bleeding. or rebleeding patient. Sometimes there might be vessel injury or rupture because of devices, this endovascular devices also. In such situation, as I said, we should bring down the blood pressure. We should surgeon is asked to stop the bleeding by various means, and by that, if sometimes if patient deteriorate, we might need to shift the patient to operation theater for decompression. Occlusion complications are also common, like thromboembolism. Sometimes, after doing thrombectomy, the patient will have again thrombus. So you should take a repeat run after 20 minutes or so, and if required, you have to give more heparin. Arterial dissection is also seen in certain patient. Vasospasm is common in aneurysm patient. It can happen up to even after 7 to 10 days. So you should be careful that it doesn't happen. And if it happens, we can give in oral nimodipine is given in all this patient. And if it happens, we can go for intraarterial nimodipine in this patient. Intravascular device or material migration is sometimes seen, and the surgeon should treat it accordingly. Contrast-induced anaphylaxis also seen in some of the patient, and contrast nephropathy is also reported if patient is diabetic or some renal issues. Sometimes a patient has hemorrhage at the puncture site, groin hematoma and retroperitoneal hematoma. Recently, only before few weeks only, is one patient came from the peripheral center. Patient underwent coronary angiography through femoral route, and patient had huge groin hematoma. So we had to explore it. So proper staff should apply proper pressure after removing the arterial sheath, so that it doesn't happen. So you should be watchful for all these complication in the postoperative period, as well as in the intraoperative period. Post-procedure care, we should go for neurological assessment as early as possible. Sometimes we need CT scan in the post-operative period, so that we can assess the things. Blood pressure management, again, it is important. If it is for yeah, aneurysm, we try to keep it bit on higher side so that there is no vasospasm. If it is things like AVM, then we opt for lower blood pressure. We should look for contrast-induced nephropathy, because sometimes very high doses of contrast are used. So we should be careful about it also. So after looking about this general recommendation, we will look at procedure-specific recommendation. Like for aneurysm, always general anesthesia is preferred. It is not prudent to go for conscious sedation in this patient. The main goal for the anesthesiologist is to maintain the hemodynamic stability and adequate cerebral perfusion and oxygenation. So we should be careful at the time of induction. There should be no rise in blood pressure. It is recommended to keep it below 160 systolic. Um, so that chances of aneurysm rupture can be reduced. Uh, because of catecholamine surge, because of aneurysm rupture, sometimes patients have neurological stress cardiomyopathy. So, if it is there, we should be careful while induction of the patient. Otherwise, it will lead to severe hypotension. These patients have ECG changes of left ventricular strain also. So it mimics like MI. So you should go for other investigations to rule out MI. Pulmonary edema is also common. It can be cardiogenic or neurogenic or mixed. If it happens, we require ventilation and PIP to treat it. Vasospasm, as I said, it can happen up to 7 to 10 days after procedure. So even in the post procedure period, we should look for vasospasm, and if it happens, we should treat it accordingly. AVM, AVF, again, GA is the preferred choice. You need deliberate hypertension and hypotension in some phases. After AV exclusion, cerebral hyperperfusion and consequent edema and hemorrhage may result from abrupt restoration of the cerebral blood flow to chronically hypoperfused vascular beds that have lost their autoregulatory capacity. Basically, this area has no autoregulatory capacity. So when there is a sudden increase in the blood flow, ICP will be increased. There are chances of that patient will have cerebral edema, which will lead to unconsciousness, seizures, or something like that. So we should maintain the blood flow, blood pressure 20 to 30% below the basal value during the recovery phase. That may protect against this complication. So we should be careful during procedure. As I said, initially hypertension is advisable. Then once we do the embolization, we should go for a little bit of hypotension to avoid this complication. Stroke, again, this is a big topic, but we will look at it briefly. How should we treat the patient? So when patient comes to the emergency department, we should stabilize the patient, assess the patient. We should send the patient for CT scan as early as possible, and we should rule out the intracranial hemorrhage. It can be ICH or it can be tumor bleed. If it is there, we should go. We should look for treat it. Should look to treat it. But in this situation, most of the time it is said that 80% of the time it is ischemic stroke rather than stroke because of bleeding. So if it is acute ischemic stroke, we should treat according to time lost before patient comes to us. If it is less than 4.5 hours, we can go for thrombolysis and consider endovascular treatment if required. If patient is not responding, if it is 4.5 to 6 hour, we should directly go to the endovascular treatment. And if it is more than 6 hour, we require some advanced imaging to consider endovascular treatment. It is said that you can go up to 24 hours, but you require some scanning that there are areas of brain which are still viable, still survivable. In such cases, we can go for endovascular treatment. So, a patient is eligible for EVT like a pre-stroke MRS score that is 0 to 1. These are various score like NIH as an NIH stroke score that should be more than 6. These are basically scores which can either help to diagnose the prognosis, or it can help us to know the current situation. So if it NIHS is score is more than 6, it means it is a mild to moderate stroke, not a very mild stroke. So in such situation, we should go for EVT. If there is large vessel occlusion, we should go for EVT. MRS score, it is basically 0 to 1. That means a very mild symptoms or no symptoms at all. In such situation, we should immediately go for EVT. We should, if it is yes, we should transfer to angiography shoot and alert anesthetic team. If it is not there, we should transfer the patient directly to stroke unit and manage conservatively. So one patient arrived to the angiography shoot, we should go for we should take handover from the emergency department nurse or stroke registrar or paramedic team if patient is arriving from distant hospital. We should flush IV cannula, connect IV fluid. If cannula is not done, then should we preferably it should be inserted in the left arm. Then we should go for investigation like ECG, SpO2, invasive BP is not routinely required, but can be monitored via femoral sheath. Invasive, we should not waste time in putting invasive line. You can go for 3-minute NIBP and treat the patient. Always we have to remember that time is brain and we should not waste any time. We should talk with neuroradiologist and decide to go for whether we should go for GA or LA plus conscious sedation. If there is any doubt, we should go for GA. So GA is recommended for patient with agitation, reduced GCS, nausea and vomiting, large dominant hemisphere stroke, and posterior circulation stroke. While if patient is conscious and cooperative, we should aim for SpO2 more than 94 and we can go for LDI and conscious sedation. So if we are when we are going for GA, irrespective of anesthetic technique, two most important anesthetic goal are minimizing any time delay and hemodynamic control. So we should not delay the time, and we should control the BP between 140 to 180 systolic. We can use drugs like labetalol infusion to maintain the blood pressure. Airway management should be done with tracheal intubation. Uh, um, in all patient, and we should go for rapid sequence intubation in non-fasted patient. We can maintain the anesthesia with the anesthesia of our choice, but I prefer propofol, sevoflurane, and atracurium on my patient. Aim of PaCO is 4.5 to 5 kPa. It is roughly 25 to 35 in our ETCO2 monitor, and aim of SpO2 is more than 94%. In conscious sedation patient may require small doses of fentanyl 12.5 to 25 microgram in titrated to effect before groin puncture and injection of the contrast. Post procedure, we should look in LA plus conscious sedation patient. We will go for straight to hyperacute stroke in it, while in GA we should shift to neuro recovery room. If ICU admission is required for any reason, it is to be arranged via the stroke team. This is the guideline by Society of Neuroscience in Anesthesiology and Critical Expert Consensus Statement and Anesthetic Management of Endovascular Stroke, and they have prepared some guidelines and recommendation. Preoperative evaluation for anesthesia should be done as quickly as possible to avoid any delay in endovascular therapy. So when patient is of stroke, we should not waste any time in pre-op assessment. We should do it very quickly, and we should follow ASA standard for emergency procedure. For anesthesia management, GA is recommended in patients who are already intubated in medical reasons. This as simple as that. GA is recommended for uncooperative patient and most patient with posterior circulation stroke. Local anesthesia with sedation and GA are feasible option for cooperative patient who can protect their airway, but anesthesia related procedures should be done as quickly as possible to avoid delay in the endovascular treatment. In all patients receiving LA with sedation, the anesthesia provider should be prepared for rapidly convert to GA if needed. This is a big challenge. If you when you need to convert to GA, it is really difficult because you are in the cath lab where there is C-arm on the head end, and you don't have adequate help. Yeah, so you should be prepared with everything while doing this thing. Anesthesia technique and pharmacological agent should be individualized based on the clinical characteristics of each patient. Recommendation for management of oxygen and ventilation, as I said, tracheal intubation is recommended for patient with decreased level of consciousness or signs of brain stem dysfunction with compromised protection of airway reflexes. Supplementation oxygen, mental oxygen administration is recommended during moderate or deep sedation. All patients undergoing endovascular treatment of AIS should be monitored with continuous pulse oximetry and capnography. FiO2 should be titrated to maintain SpO2 more than 92% and PO2 more than 60 mm of Hg. Ventilation should be adjusted to maintain the normocapnia, that is 35 to 45 mm Hg under GA. Respiratory depression induced hypercarbia should be avoided during procedural sedation. This is a big complication. Sometimes patient will slowly develop hypercarbia, which will lead to increased ICP and patient will become unconscious. So we should be always careful about it when we are doing sedation. Hemodynamic management, as I said, our goal is to keep it between 140 to 180 mmHg of systolic or less than 105 mmHg of the diastolic blood pressure. There is insufficient data to recommend a specific vasopressors to support blood pressure. You can use vasopressor of choice should be based on the individual patient characteristic. Blood pressure targets may be adjusted in communication with interventionists and neurologic following successful recanalization of occluded vessel. Fluid management, You should maintain the euvolemia during the procedure. Glucose containing fluid should be avoided unless treating the serum glucose level less than 50 mg/dl. For temperature, we should maintain the normothermia. Some of there are some there are no enough recommendation for hypothermia. If patient has fever, we should treat it. Recommendation for intra-procedure monitoring, as I said, ECG, SpO2, EtCO2, and respiratory rate monitoring is must. Blood pressure should be monitored continuously or non-invasively at least every 3 minutes. For anticoagulation, we should be prepared to administer heparin throughout the procedure as required by the neurointerventional team. And we should prepare to administer protamine if it is required in case of bleeding. For glycemic management, serum glucose should be sampled at least once every hour during endovascular treatment. We recommend that insulin treatment of HG should be initiated for glucose level more than 140 mg per dl. Protocol-driven interventions infusion recommended to be used to control the sugar rather than subcutaneous insulin. So we should go for IV insulin. Serum glucose concentration should be maintained in the range of 70 to 140 mmHg with treatment for hypoglycemia be initiated if it is less than 50. So our target is 70 to 140. For complication, in case of ICH, heparin effect may have to be reversed immediately with protamine. After ICH, systolic blood pressure is recommended to be maintained more than 140 mmHg. In case of arterial hypertension, rapid lowering of blood pressure during stroke is not recommended. You should not reduce it suddenly, otherwise it will lead to more complication rather than helping. Labetalol and nicardipine is recommended for the patient with ICH to maintain the systolic blood pressure less than 180 and mean pressure below the 130. In the post-operative period, patient should be admitted in the ICU specializing in the neurovascular care or stroke unit after the procedure. Continuous hemodynamic monitoring should be continued in the ICU stroke unit. So these are the recommendations for stroke. We should follow it. In carotid stenting, it is advisable to do monitor anesthesia care rather than going for sedation or um, general anesthesia, because we want to monitor the neurological status during the procedure. Severe bradycardia or asystole may occur due to stretching of the carotid body. So while doing stenting, they dilate the carotid artery, and at that time, there are all chances that patient will have severe bradycardia and asystole. Anesthesiologists should be cautioned regarding this unpredictable reflex. So whenever they do it, they tell us that they are doing dilatation so that we can be ready with atropine and all those drugs. If severe bradycardia or asystole occur, we should go for IV atropine 0.5 or 1 mg, or glycopyrrolate can be administered, and it responds very nicely to this treatment. Cerebral hyperperfusion syndrome that can happen after the carotid stenting, that is characterized by ipsilateral headache, hypertension, seizure, and focal neurological deficit. It often occurs in patients with increase of more than 100% in cerebral perfusion following the procedure compared with the baseline. So sometime after stenting, there will be a very high increase, like 100% increase in the cerebral perfusion because of opening of the carotid artery, and it will lead to cerebral hyperperfusion syndrome. Uh, as perfusion is pressure is as perfusion is pressure dependent in patient with CHS, strict blood pressure control is recommended. If it is recommended to maintain the systolic blood pressure below the 120 mmHg, and also to adjust the systolic by about 80% of the preoperative systolic pressure, so that there is no problem. So to take home message, increasingly complex neurointerventional procedure will continue to challenge anesthesiologists, and understanding of current and future development in this field is important. All the general principles of governing intracranial hemodynamics and function are similar. Patient undergoing different procedures for different pathological condition may require much different type of anesthesia and monitoring care. So all these procedures are require different type of care. Successful intraoperative management of these challenging patients require a basic understanding of the pathophysiology and neurointerventional demands of the procedure, all of which start with a thorough preoperative evaluation and the preparation for the patient. So we should uh, do preoperative evaluation properly, but very fast, and we should do the preparation accordingly and treat this patient so that we can have a better outcome. So this is all about neurointerventional radiological procedure. Thank you. Thank you very much.